diabetes and dyslipidemia.
Diabetes and dyslipidemia. Are you taking any medications?
تونسيا معكم.
No.
No. Okay. Do you smoke? Do you drink alcohol?
Yes, I smoke, but I don't drink alcohol.
Okay. How many cigarettes per day?
About
40 per day?
Yes.
Okay. Since how many years?
Since the age of 29.
Okay. Since the age of 29. Have you ever been with a cardiologist before? A cardiology consultant?
Yes.
Good morning. Can you hear us?
I had a heart attack, and a stent was placed. I think.
Can you hear us?
I was told that my heart isn't pumping blood well anymore.
Okay.
At least that's what I understood. That I stopped my medications when I thought that everything was okay.
Okay, so you thought everything was okay, so you stopped every medication.
Yes.
This was 3 years ago. So
no, I stopped my medication since about 1 year.
About 1 year. So you're not taking anything?
No.
For diabetes, for dyslipidemia, for your heart disease, you're not taking anything?
I did some blood tests, and the diabetes test was okay, so I stopped everything.
You stopped taking anything. Okay. So how can I help you today? What's your complaint? I can see you're touching your chest. What's wrong?
My chest, I have chest pain, and it's burning like fire here, just like here. And I have some troubles in breathing, especially when I lie down.
Okay, especially when you lay down. Since when do you have this chest pain?
Since 4 days.
Since 4 days. Does the pain radiate? Does it go somewhere?
Yes, to my arm and
the jaw. Okay.
Yes.
If I may ask, this has been evolving since 4 days. Is there anything new that made you come today, particularly?
Yeah. Since 4 days, the pain was about 2 minutes, and it stops, and then I have it again. Okay. But since 4 hours, it's here, and it never stopped.
Okay, it's becoming more intense.
Yes, and I feel that I'm like to lose consciousness.
Okay. Okay.
Like
so
that.
you can't breathe well, especially when you lay down. You have chest pain and you feel a little bit dizzy, right?
Yes.
Okay. So we'll run some blood tests. I will be examining you. We'll go through some investigations, and I'll let you know step by step if there is anything that is related to a cardiac condition, especially that you have dyslipidemia, that you've had a stent before. So this might be another
just do
heart
it.
attack. Okay.
Thank you.
So we'll start with Dr. Muna. Are you still with us? We'll start with the case analysis. I'll try to share my screen. Okay. So can you see my screen? Can you just confirm that you can see my screen? This was a 54 years old male. Of course, Noor doesn't look like a male, but it was a 54 years old male. He had diabetes, dyslipidemia. He was a smoker. He had coronary artery disease in 2021, an anterior STEMI seen at day 4, complicated with heart failure and apical thrombus. Ah, d'accord, c'est un autre écran. Partager l'écran.
Tout l'écran.
D'accord, c'est bon?
tout l'écran.
There is no screen.
Okay.
Okay, we're having
There is no.
Ouais.
just 1 second. Oh, okay.
Tout l'écran, comprends?
Okay, très bien. Can you see my screen now?
C'est bon, c'est bon.
So it was a 54 years old male, diabetes,
Yes.
dyslipidemia. The patient was a smoker. He had coronary artery disease in 2021. He had an anterior STEMI seen at day 4. Probably complicated with heart failure. Well, he brought his report, so it was complicated with heart failure, apical thrombus due to an acute occlusion of the distal left main trunk. So he had a PCI of the left main trunk with a drug-eluted stent. He doesn't take any medications, and he's complaining of chest pain at rest, radiating to the jaw since 2 days, with an aggravation since 4 hours, orthopnea and sweating. And he describes some dizziness, but no syncope, no real syncope. On physical examination, patient was sweating, upper airways were normal, high blood sugar levels with no acetonuria, the correct temperature, no fever, normal respiratory rate, correct oxygen saturation, a blood pressure of 150 millimeters per mercury, no peripheral signs of hypoperfusion. The patient was conscious, alert, and oriented to time, places, and persons with no focal or systemic neurological defect. He had vesicular breathing with bilateral basal coracoles, regular heart sounds, no murmur, heart rate of 100 beats per minute, and good peripheral pulses with no edema. So this was our patient's ECG. I'll give you a few seconds to take a look at it. On the lab tests, he had normal hemoglobin levels, normal renal function, high troponin levels, normal ABGs, and no further abnormalities. This was the coronary angiogram of our patient. I'll let you take a look at it. This was the coronary angiogram after our intervention. You can see the wires. We had a PCI. On the TTE, the patient had dilated left ventricle with left ventricular hypertrophy and reduced ejection fraction. He had elevated left ventricular filling pressures, hypokinetic inferior, septal, and anterolateral walls with moderate mitral regurgitation, non-dilated right ventricle, preserved systolic function, and no pericardial effusion. So on day 5, we get a call from the on-call nurse for a white tachycardia, a white QRS tachycardia on the monitor. The patient was unconscious. We had a pulseless cardiac activity, electrical cardiac activity. We started the resuscitation protocol. The patient also had an external electrical cardioversion, five external electrical cardioversion. And this is the ECG after external electrical cardioversion. I'll give you a few seconds to look at it, and I think you ought to know that on the coronary angiography, there was no stent thrombosis because that was the first thing we thought of. So this was a 54 years old male. He had diabetes, dyslipidemia. He was a smoker. Coronary artery disease, PCI of the distal left main trunk 4 years ago with a drug-eluted stent, poor compliance to medications, doesn't take any medications. He presented at the ER complaining of chest pain at rest, radiating to the jaw since 2 days with an aggravation since 4 hours, orthopnea, Clinically, he had high blood glucose levels without acetonuria, tachycardia, heart rate at 100 beats per minute. He was hypotensive with no peripheral signs of hyperperfusion, with bilateral correctals and a correct oxygen saturation. On the lab test, we had high troponin levels, and on the GTE, we had the dilated left ventricle, hypokinetic inferior and first septal and anterolateral walls with a reduced ejection fraction. We also had elevated left ventricular filling pressures. On the first ECG at presentation, our patient had irregular sinus rhythm at 100 beats per minute, narrow QRS complexes, ST segment elevation in inferior leads with a reciprocal ST depression in the interior leads, and left ventricular hypertrophy. On the coronary angiogram, he had a right coronary artery occlusion. It doesn't show here, but we had a permeable left main trunk. The door to balloon time was 60 minutes. He had a PCI with a drug-eluted stent on the right coronary artery. On day 5, we are called, as we said, for a wide QRS tachycardia. We had a pulseless electrical activity, so the patient was actually in cardiac arrest. On the ECG, we had a tachycardia at 300 cycles per minute with wide QRS complexes at around 180 milliseconds. We had doubts regarding atrioventricular dissociation. I don't know if you can see it right here. And we had R waves in the AVR leads. So, ça passe? Ça passe pas. You can't see the other slides, right? Vous pouvez plus voir.
You can see the slide that says day 5, cardiac arrest.
Yes. Just 1 second. Je partage plus. Just 1 second. I'm having troubles sharing the screen. On ne pouvait plus rien voir, docteur Halouche. Present online يقول لي يخرج لي يقول لي present online. Je vais essayer. D'accord. You can see now?
Day 5, cardiac arrest, yes.
The patient, we went through a resuscitation protocol with the external electrical cardioversion. After the resuscitation protocol, we regained the patient was conscious with a Glasgow coma score of 15 of 15, normotensive. We had an irregular rhythm. And on the ECG, polymorphic PVCs with ventricular heterogeneity. We put patient on amiodarone, but he presented hypotension, so we went to lidocaine. We couldn't put any beta blockers in the framework of acute heart failure because, as I told you, he had he had orthopnea with basal correcals. On the coronary angiogram, there was no stent thrombosis. So the first potential diagnosis that we discussed was ventricular tachycardia. We had the ischemic cardiomyopathy, the heart failure, the white QRS complexes, quite white QRS complexes, the hemodynamic instability, although it could be seen in SVTs. We also evoked SVTs, but the rate at 300 cycles per minute, the very wide QRS complexes, we were around 180 milliseconds. The atrioventricular dissociation, the R wave, and the AVR lead, altogether, they made us think that the VT diagnosis was not plausible. But the second question that we asked was, why did we have a VT? In the framework of an acute coronary syndrome, and even though we are 5 days away of the episode, of the initial episode, and the patient was revascularized, we thought of an acute ischemia, so a stent thrombosis. But the second coronary angiography control didn't show any stent thrombosis. So the second hypothesis that we had was a ventricular tachycardia on a scar, because the patient already had a history of coronary artery disease, heart failure, reduced ejection fraction. The VT was rather monomorphic, and usually acute ischemias. We noticed polymorphic VTs in acute ischemias. So our final diagnosis was inferior ST segment elevation myocardial infarction seen at 4 hours, complicated by heart failure and ventricular tachycardia, all due to an acute right coronary artery occlusion, as showed the coronary angiogram. Okay.
Dr. Arkush, Dr. Azaka, would you like to comment?
I'm
sorry.
Hello.
Dr. Arkush,
Good morning.
Good morning.
What this noise? What? Hello. Actually, this is a very nice and elegant presentation and very
I'm
nice
sorry.
tips.
We didn't end with the take-home messages, so
okay.
if you give us
I'm sorry.
I'm really sorry.
I'm really sorry. Dr. Mona asked me to comment. Just
Okay. So just for the evolution, 24 hours later, our patient had another cardiac arrest due to ventricular fibrillation. Of course, we don't have the ECG. It was a VF. We were resuscitating the patient, and the resuscitation was not successful. So what we're asking you is, what went wrong? What do you think went wrong? We were 5 days after an acute coronary syndrome. Should we have implanted an ICD? Although we were in the first 40 days of the acute coronary syndromes, should we prescribe a temporary use of a wearable cardiovertebral defibrillator? It's true we don't have that in Tunisia, but maybe it's something we should have thought of. Our take-home messages would be that in the presence of tachycardia, ventricular tachycardia, always think to exclude reversible and acute causes such as ischemia. Always consider ventricular tachycardia in the presence of wide QRS complexes, particularly in the context of ischemic cardiomyopathies or heart failure. It's advisable to consider a wearable cardiovertebral defibrillator 48 hours after an ACS, particularly in patients like ours who have pre-existing ventricular dysfunction, who have ventricular arrhythmias, who have incomplete revascularization, and patient with coronary artery disease. Always think of two possible causes for ventricular arrhythmias, whether it's reversible, so ongoing acute ischemia, or VTs on a scar. The last thing that we conclude with is that before implanting an ICD in such patients, it's important to ascertain whether complete revascularization has been achieved or not. Let us know what you think, and tell us when we could go to the MCQs.
Good morning, everybody. Actually, it's a very nice and elegant presentation and very nice analysis.
Please.
You cannot hear me?
We can hear you. Can we see? Can you turn the video on?
Okay.
Hey, there you are.
Oh, hello. Actually, it's a very nice, very elegant presentation, very good analysis of the case. Concerning the tachycardia, in the setting of ischemia, I wouldn't ever think for SVT with aberration, even if there is a association between the atria and the ventricle. no differential diagnosis. It's just VT. It's actually very rapid. It's going into ventricular flutter. I think we don't have to spend much time in analysis of the ECG if it is VT or SVT. It's definitely VT. Okay. I would like to ask about the electrolytes of the patient. Sometimes the myocardium is very vulnerable for electrolyte imbalance. If the potassium and magnesium is properly, we need high potassium. Okay, yes, we always need above 4 milliequivalent, as you know. As regards the implantation of an ICD, mostly this is a scar. Properly, as you said, we have to do an angiogram to do to know that the stent is patent and everything is okay for the vessels. But we have for the acute coronary syndrome, we always see the time of occurrence of the ventricular arrhythmia. If it is early within the early 48 hours, or if it is after that, or after 40 days, as it is defined by the guidelines. Okay, actually it happened 5 days post MI. Okay, and so this patient is eligible for ICD. I don't think it's a wearable ICD. It's an ICD. But the point is that he might have several attacks that he might need to be ablated or something like that. It's not enough to have just have an ICD. He will have several shocks from my point of view. It seems that it is a scarry area intermingled with a healthy area. This is why he has attacks of VT. Okay. Thank you so much for your presentation.
Thank you.
Amna, would you like to comment? Dr. Amna, would you like to comment?
Sorry for the noise. I think the patient was managed properly, and as you said, Dr. Azza, we have to plan for an ICD implantation and VT ablation because the patient was electrically unstable, and we are facing an electrical storm, arrhythmic storm. So the patient, if he survived, I think they will presenting the guidelines about the electrical storm. So the patient would be managed, would be eligible for sedation, for neurological sedation.
Yes.
I have a question. Dr. Azza is asking about the electrolytes. Did you have the electrolytes?
Yes, we didn't have any hypokalemias. We don't have anything that could explain a reversible cause that could explain VT. I didn't. I should have mentioned the potassium levels particularly, but I just wrote that we had no other abnormalities. But yeah, it's true. We had normal potassium levels.
Was he diabetic? I missed that. Was he diabetic?
Yes.
Yes.
Yes, and we had the ABG. We mentioned the ABG. He had no metabolic cause that could explain the VT.
So, what do you think happened, in your opinion? You were there.
I think that the acute coronary syndrome was a trigger for ventricular tachycardia that happened on a scar of his interior myocardial ischemia and fracture.
Ischemic cardiomyopathy.
Yes.
And the patient had heart failure with reduced ejection fraction as well. So he had a lot of things that made him.
And before this event, the patient before this event, he was not on good medical therapy. So he was vulnerable rhythm disorders.
Okay, so he was in heart failure. He was in heart failure. 36, Dr. Mario's saying. Okay.
So we have some MCQs that we share. Okay. And then we go with the guidelines about the ventricular tachycardia in ischemic patients.
Okay, so I'll share my screen again. I'm used to I got used to the Zoom, so
I think this is easier actually. Okay.
yeah, it's easier. We're just creatures of habits.
It's on the right hand side. Okay.
So you can see my screen now, right?
Yes.
Yes. Yes.
Okay. So we prepared some MCQs, tachycardia MCQs altogether, not just those related with our case. We'll start with some easy one. Which of the following do you think is in favor of supraventricular tachycardias? Time to peak, to first peak, more than 40 milliseconds in lead 2, R waves in AVR lead, or RS complexes in leads V1 to V6. Yemen team, are you with us? Egypt team, are you with us?
Actually, just Dr. Mario today.
I think the R wave in AVR leads. I think R waves in AVR.
Okay, we're talking about supraventricular tachycardia, then, Dr. Mario. Yemen team?
is complex in 1 6 بيتاج.
Yemen team, can you hear us?
Discussing the answers, I think. They're thinking, sharing.
Are you with us?
Dr. Akram, do you have an answer? You're muted. Your mic's
C.
C. Okay, great.
Dr. Mario thinks it's B.
Okay.
What's the answer?
In favor of supraventricular tachycardias, the presence of RS complexes in leads V1 to V6, R waves in IVR lead, as we'll see in the algorithm that I'll be showing in a minute. R waves in AVR lead are rather in favor of ventricular tachycardias. So which of the following you think is in favor of ventricular tachycardias? Is the absence of an atrioventricular dissociation in favor of VT? Is the presence of a structural heart disease, even on the history, and while taking the history of the patient or on the TTE, etc., in favor of VTs? Or do you think that the heart rate around 150 beats per minute could be in favor of VT?
B.
تشعل المكسرة هي حل المكسرية مرة
Structure heart disease. B.
موجودة لا
Dr. Mario?
B.
B, okay. Dr. Akram?
B.
Okay. So exactly, whenever we have structural heart disease, we should think of a VT. On VTs, we usually, not always, but we can have an atrioventricular dissociation. And when we have a heart rate around 150 beats per minute, we can't really say if it's a VT or an SVT. I think more of an atrial flutter whenever we're around 150. This is actually a quite simple algorithm. This is actually a quite simple algorithm with criteria to try to differentiate wide QRS complexes tachycardia, are they VTs or SVTs. So lead AVR and lead AVR, the R wave and the time to first peak more than 40 milliseconds. In lead 2, time to first peak more than 40 milliseconds, and whenever we have a structural heart disease, so an ischemic cardiomyopathy, a left ventricular, reduced left ventricular ejection fraction. Yeah, it's very useful in emergency departments. It's quite easy to use. So third question, which of the following can be cause of a tachycardia? Hypothermia, hypercalcemia, or acute heart failure? This is our gift to other teams. Dr. Mario?
Concerning this case or in general?
No, in general. These are quite general questions.
I think acute heart
Okay. Okay, Dr. Akram?
C. Acute heart failure.
Hypercalcemia. Okay. So of these causes, acute heart failure cause tachycardia. It's actually one of the first symptoms and signs of acute heart failure. And it's important, especially when we have a sinus tachycardia, to treat the cause, not just think of. Can you please unmute your mics? There is an open mic and I can hear my echoes. Okay, great. So as I was saying, whenever we have a sinus tachycardia, we should rather try to treat the cause of the sinus tachycardia. So fever, infection, pulmonary embolism, acute heart failure, etc., and not focus on the tachycardia itself.
May I add, for acute heart failure, it may causes supraventricular and ventricular tachycardia. For hypothermia, it causes bradycardia. Also for hypercalcemia. Just to notice that in acute heart failure, tachycardia maybe originates from the supraventricular and from the ventriculars. We may have very fast AFib or atrial flutter, or as she says, sinus tachycardia, and of course ventricular tachycardia.
Okay, thank you, Dr. Alouche. So we'll get back to the fourth question. Now we're changing a little bit the subject, but still when talking about tachycardias, do you think that when localizing an accessory pathway with the RS ratio algorithm, when we have an RS ratio more than 0.5 in V1 and more than 1 in AVF, do you think that we could say that the accessory pathway is on the left side, on the right side, or do you think that we don't have enough information to such an affirmation, that we need more information to localize the accessory pathway? Dr. Mario?
Okay. I would go from the when R2 is more than 0.5 in AVR and more than 1 in AVF. I think it may be from the right side.
Okay, Dr. Akram?
A. Left side.
We have a tool of in V1.
What?
Razza?
I mean, we have a tall R in V1.
A taller R.
Yes, a tall R in V1.
Yes.
It's a big R in V1. Just not to be confused with more than 0.5 or less than 0.5.
Yes.
Yeah. Mhm.
So the right answer is that the accessory pathway is on the left side. There's actually a quite easy algorithm, and it's easy to understand because it's derived from the electrical activity in the heart. It's the depolarization wave that goes from the left side to the right side, and that way we'll have an RSA. So when we're on the right side, we are receiving the right leads are receiving the electrical wave. That's why we'll have a tall R wave in V1. This is the algorithm we were talking about. There are quite different algorithms, but this is an easy one because it's the RS ratio in V1, AVF, and V2, just in these three leads. So which of the following, now we're talking about AVF. Can you please mute the mic? Dr. Azza, would you like to say something? Hello.
Raza? Lemon, you need to mute.
Very noisy. Very noisy. Yeah.
Okay, should I go on or?
Yes.
I thought Dr. Azza wanted to make a comment. Okay.
Yeah.
So, which of the following do you think is a first-line indication of an AFib catheter ablation? A contraindication to anticoagulation, a fail of rhythm control with antiarrhythmic drugs, or a tachyarrhythmia-induced heart failure? Dr. Akram?
A. Contraindication to anticoagulant.
Okay, Dr. Mario?
I will go with A.
You'll go with?
A.
A?
Yeah.
Okay. So the right answer is actually a tachyarrhythmia-induced heart failure, because whenever we'll do an AFib catheter ablation, we won't stop the anticoagulant if there is an indication for anticoagulation. It will be useful for stopping antiarrhythmic drugs. That's the point of the AF catheter ablation somehow. When we have a fail of rhythm control with antiarrhythmic drugs, we're not on the first line indication anymore. But whenever we have a tachyarrhythmia-induced heart failure, AFib catheter ablation is actually indicated as a first line treatment.
May I comment, please?
Yes,
when we have the contraindication to anticoagulation, there is not the indication for AFib catheter ablation, but we have to try left occlusion of the left appendage, left atrium appendage to stop anticoagulant therapy. Because if the patient has the indication of anticoagulation according to the CHATS FAST2 score, we have to anticoagulate the patient even if we have a successful AFib ablation. Because the indication of the anticoagulation is according to the patient's specificities and patient's and pathologies like hypertension, diabetes, and heart failure.
So this is as we were saying, the ESC guidelines, 2021 ESC guidelines for the management of atrial fibrillation. And as you can see, in patients with the tachyarrhythmia induced heart failure, we could indicate as a first-line treatment AFib catheter ablation. For those who know it, a ventricular tachycardia is certain when the Jastrzebski score is less than 10, more than 3, or more than 5.
More than 5.
Okay, and Dr. Akram?
C, more than 5.
Okay. You were quite close, but not that much. So this is a ventricular tachycardia score. And as you can see, whenever we have more than 3 criteria, we are in front of a certain tachycardia, ventricular tachycardia. It's a score that takes into consideration the AVR the R leads in AVR, the R waves in AVR lead, the atrioventricular dissociation, the time to first peak more than 40 milliseconds. The width of the QRS complexes. And it's a score that goes from 0 to 8 points. You can check it on the site that I've just put just to take a look. So that was it for us. I hope it was useful, and let me know what you think again.
I'm not Dr. Azza.
Thank you so much. It was very beneficial. Very nice and thank you for it.
Thank you. I have no comment.
I'm not Anush.
Thank you. It was very useful. No further comments. I think she said the essential of the tank. Thank you.
Thank you, Tunisia. You have a solo presentation, your guidelines?
Yes, okay.
Okay.
And guidelines.
Raisa, do you have a comment? Would you like to comment?
No, thank you so much.
They're gonna give their sole presentation and then we're gonna have a debriefing on Google Forms.
Okay.
Okay.
Tunisia, go ahead.
Yes, just 1 second. We're trying to share the screen again.
Okay.
Good morning again, everyone. I'm going to present you the ischemic ventricular tachycardia guidelines. You see the screen, right?
Yes.
Okay.
Therapy.
So, according to the European guidelines, whenever we are in front
We can't hear you. We're not getting any sound.
to PCI, if not contraindicated, should be used with an urgent coronary artery angiography and revascularization.
But I'm not getting any sound. We can't hear you. We can't hear you. We can't hear you. No sound. No sound. I don't know, we can't hear anything. Can't.
Sedation for comfort.
I don't know, we can't hear anything. We can't hear anything at all. Can you start over, please? Anna, can you start over? We can't hear anything. We can't hear anything.
Dr. Muna, you can hear me.
No, we can't. Can you start over, please? We didn't hear anything. Can you start from the beginning, please, Dr. Amna?
Okay, I will start from the beginning. Okay.
Yes.
So I will present you ischemic ventricular tachycardia guidelines. According to the European guidelines for the prevention and treatment of ventricular arrhythmias in the acute phase of STEMI, beta blockers and by intravenous prior to PCI, if not contraindicated, should be prescribed with an urgent coronary artery angiography and revascularization. In front of ventricular arrhythmia, further revascularization is, if appropriate, a repletion with potassium and magnesium, beta blockers by intravenous, and sedation for comfort are recommended. If you have a recurrent ventricular arrhythmia, intravenous amiodarone should be recommended, and intravenous lidocaine and deep sedation may be useful. After that, if we have a recurrent ventricular arrhythmia, catheter ablation and overdrive pacing should be used, and autonomic modulation and then a mechanical circulatory support may be useful. So for our patient, intravenous beta blocker or amiodarone treatment is recommended for patients with polymorphic ventricular tachycardia and VF useless contraindicated. Prompt and complete revascularization is recommended to treat myocardial ischemia that may be present in patients with recurrent ventricular tachycardia and or ventricular fibrillation. So we were in front of a recurrent ventricular tachycardia with hypertension. So we use it when we use it amiodarone. For the guidelines, treatment of recurrent ventricular tachycardia with hemodynamic relievance despite repeated electrical cardioversion with lidocaine may be considered if beta blockers, amiodarone, and overdrive stimulation are not effective or applicable.
Dr. Amna, do you know what 2B means? Can you tell us what 2B means?
Excuse me?
Can you repeat, Dr. Mona?
2B, what does that mean?
2B,
maybe use it. It may be used. It's not mandatory, but if there is no solution, we can use this.
And level C, level of evidence C?
There is expert.
It's an expert concerned. It isn't some reviews or meta-analysis.
It was based on studies and cohort study or.
It's just an expert opinion.
Yeah.
Level C is just an expert opinion. There's nothing to prove or disprove anything.
In this concern, it's quite difficult to do studies and compare patients with different protocols because it's a rare condition and it's very complex, and we have to save lives, so we use almost these situations, this level of evidence.
Yeah, so that's my point exactly. Most of the evidence-based is just expert opinion. Most of the things for this arrhythmia is just expert opinion. Okay, thank you. Continue, please.
Okay. So if patients with recurrent life-threatening ventricular arrhythmia, sedation or general anesthesia to reduce sympathetic drive may be considered. Also, ICD implantation or the temporary use of a wearable cardioverter defibrillator may be considered if we are less than 40 days after myocardial infarction in selected patients, like incomplete revascularization, pre-exciting LV ejection fraction dysfunction, occurrence of arrhythmias after 48 hours, and polymorphic VT or VF.
Excuse me. To reduce this sympathetic drive, we may use non-selective beta blockers to reduce this sympathetic drive, like propranolol, if the patient is conscious, or we may have the surgical strategy to cut the sympathetic nerve ganglions.
Okay. So if our patient had survived, in patients with ischemic heart disease who either survive an acute coronary syndrome due to ventricular tachycardia or ventricular fibrillation, or experience hemodynamically unstable VT or stable sustained VT not due to reversible causes, an ICD is recommended if meaningful survival greater than 1 year is expected. So the ventricular tachycardia occurred 5 days after the ischemic event, and the coronary angiography didn't show a reversible cause, plus an LV function at 36. So we are in a secondary prevention. And the patient was a survivor after ventricular tachycardia, so it was an indication for an ICD implantation according to the American guidelines. We had also recurrent ventricular tachycardia. So in patients with ischemic heart disease and recurrent ventricular arrhythmia with significant symptoms or ICD shocks despite optimal device programming and ongoing treatment with a beta blocker, amiodarone or sotalol is useful to suppress recurrent ventricular arrhythmia. In patients with prior myocardial infection and recurrent episodes of symptomatic sustained ventricular tachycardia, or who present with a ventricular tachycardia storm and have failed or are intolerant of amiodarone or other antiarrhythmic medication, catheter ablation is recommended. We have to know also in patients with insistent ventricular tachycardia or ventricular fibrillation, an ICD should not be implanted until sufficient control of the ventricular arrhythmia is achieved to prevent repeated ICD shocks. And in patients with ischemic heart disease and sustained monomorphic ventricular tachycardia, like for our patient, coronary revascularization alone is an ineffective therapy to prevent recurrent ventricular tachycardia. Because, as we said, the acute coronary syndrome also causes a polymorphic ventricular tachycardia. So, but for our patient, there were a monomorphic ventricular tachycardia, so it was really an indication for an ICD implantation.
And even VT ablation, because there is
recurrence,
and there is a scar because the patient had already an myocardial infarction and the scar is there.
Yes.
So we have the substrate and the
trigger
in this situation.
Okay, so thank you very much. If you don't have any question, I will go to the solo presentation. C'est bon. You see the screen, right?
Yes.
Okay. So for the solo presentation, the subject was natural calming herbs for tachycardia. My reference will be a review on plants and herbal component with antiarrhythmic activities and their interaction with current cardiac drugs. It was published in 2020 in the Journal of Traditional and Complementary Medicine, and this is the reference for who want to do some bibliography, because the papers say that they found about 36 herbs that have an antiarrhythmic activities, but I summarized some the most known herbs.
Ramna?
Arrhythmias and mortality rate. The antiarrhythmic effects of saffron.
Ramna, can you start over, please? We didn't hear the beginning.
Okay. Okay. Okay, my reference in this presentation will be a review published in 2020, and the results indicate that about 36 herbs or their derivatives can be effective in the treatment of arrhythmias, especially in animal anterior models. I will summarize some herbs effective on tachycardia and their interaction with antiarrhythmic drugs. This is the reference for those who want to do some big bibliography. We will start with saffron. Saffron showed a significant reduction in the incidence of and duration of ventricular fibrillation, the incidence of VT or VF, as well as the severity of lethal arrhythmias and mortality rate. The antiarrhythmic effect of saffron with a dose of 100 milligram per kilogram were comparable to amiodarone. But you have to know that 1 kilogram of saffron costs about $50,000. So experimental studies showed that cartages reduces the number of PVC, the duration of ventricular fibrillation, the occurrence of VF and VT, and mortality rate in ischemic heart disease. And I have to mention that we had it in Tunisia, and we use it to relaxation by the dose of twice daily. If you want to do some,
This is
Dr. Alouche.
This plant is very famous in Tunisia, and kids eat this plant very often. And this plant has this capsules have a relaxation effect, especially in ladies with anxious ladies and who had the tachycardia with no obvious
reason.
Because it's it calms sinus tachycardia and the sensation of palpitation in and it's very effective drug when there is no physical cause of palpitation.
Okay.
So it works on the sympathetic nervous system, calms down the sympathetic? Is that how it works, you think?
It has an effect on the potassium channel.
In potassium channel.
Right. You can see the table just below for the mechanism for all plants in the presentation. Okay.
احنا في تونس بنسميه الزعرور، ما نعرفش عندكم شيء تسمى.
زعرور? I'm not sure. Dr. Azza, do you know what that is?
لا أنا I don't know it. هي شكلها seems to be familiar, but I don't know what's its name.
Okay.
I will search for it definitely. This is very interesting.
Okay. So in an experimental study, Sophora, by the dose of 100 milligram per kilogram, significantly reduced the number of ventricular tachycardia and delayed the onset of ventricular tachycardia during the ischemia period when compared with the control group in rats. Everyone knows garlic. And according to study data in dogs, injection of garlic extract after induction of arrhythmias decreases the incidence of PVC and ventricular tachycardia. An isolated atria of red garlic extract suppressed ectopic rhythm developed by aconitine and isoprenaline, as well as prolonged ERP and sinus node recovery time in a dose-dependent pattern, and RR and QT interval were restored to normal in allicin group. So in an aconitine-induced arrhythmia models on rats, pre-treatment with arctiginin significantly delayed the onset of ventricular tachycardia, PVC, and mortality compared to the untreated ones in a dose-dependent pattern. Refers to the results of an investigation on rats indicated that orally pretreatment with berberine for 7 days before coronary irrigation could markedly decrease the duration and severity of arrhythmias during ischemia and could reverse the prolonged QT interval in compared to untreated diabetic rats. And we have it also in Tunisia. This is the medication, but Dr. Alouche said that
endocrinologist prescribes this supplement for patients to regulate their glycemia and LDL and triglyceride levels.
berberine.
And I think that's the cause of it's efficient in diabetic rats because that
it modulates
the effect of diabetes, and it's not very expensive.
It's interesting that in Tunisia you actually use these things. You're gone. We can't hear you.
Yes.
What do you think? They're really into this plant thing.
I don't have experience with these medications, but this seems to be very interesting. I have to search for it.
And they seem to really have the good results with it as well.
Yes, I think especially for those with sinus tachycardia and inappropriate sinus tachy, we have to try something like that.
Mm-hmm.
What do you think?
It sounds like they have experience using these things.
Yes. Sometimes we don't. Sometimes we don't have solutions. We don't have solutions for patients with inappropriate sinus tachy, or we can search for these alternatives. This will be a very good option, better than EP study.
Yeah, we have to try. She said that works with diabetics.
The APD.
Yes.
And diabetes.
We lost you like 2 slides back. We're still on berberine. We're still on berberine.
And now?
We didn't hear anything after berberine. We lost you. We lost contact.
Okay, I repeat, but you see the slides? Do you see the slides now?
Yes, we
do.
do.
Can you go back to berberine, because that's the next slide.
This is the next slide. You know القرفة.
Yes, cinnamon. Okay. Yes, I love cinnamon.
Okay, so orally pre-treatment with extract of cinnamomycin for 2 weeks before the ligation of the LAD coronary artery of rats showed the marked reduction of the number of PVC, ventricular tachycardia, and the duration of ventricular tachycardia in the treated group than the control group during 13 minutes of tachycardia, and the probable mechanisms were an effect on APD and the sodium and calcium channels.
Well, is there a dose for that? Like 2 weeks prior?
They didn't mention those for in the review.
Because it says for 2 weeks before the ligation of the
Yeah.
LED. You don't have a dose for it. 1 cup daily, 2 cups.
I will do some search to.
That would be very interesting.
Okay.
It's also used by diabetic patients. Excuse me?
Everybody's going to be searching after this presentation.
Yes.
It's very interesting. Even diabetes even in diabetic patients, they use this to reduce the level of postprandial.
Yes, and we use it in Tunisia usually to lose weight.
For weight loss.
It's really known for weight loss.
It's very interesting. In Tunisia, you're more into the herbology. It's very interesting.
Okay.
But have you tried cinnamon and using this stuff?
Yes, we do use it for weight reduction. This is true. We use it with ginger. I think there's a mixture for this. Yes, but I don't know something for the antiarrhythmics. This is the first time for me to hear about it. As an antiarrhythmic effect.
You can have everybody searching after this presentation.
Yes, we have to search for it.
Very interesting.
And finally, I have to present this diagram because we have to know that some plants have interaction with digitalis and they may increase the risk of arrhythmias such as aloe vera, ginger, etc. And they and
ginger increases. Ginger causes tachycardia.
No, the ginger is used to calm tachycardia.
But when used with
when used with beta blocker and digoxin and calcium blockers and statin, it may decrease their effects.
Decreases the effects of beta blockers.
Beta blockers, digoxin, and calcium blockers, and they may have interaction with anticoagulant drugs, so they may increase the bleeding risks. Okay, and finally, for lily of the valley and the night blooming cereus, they increase the effect of beta blockers, digital, and calcium blockers.
Take home message of this presentation, this algorithm is when patients are on cardiac medication, antiarrhythmic medication, they don't have to use by themselves this herbal treatments. They have to take
their medications without
to take the permission of the physician and to verify if there is any interaction between the medication, the prescribed medication, and this herbal supplements, because as we know, everything is a poison, but everything is a medication. It's about the dose.
Balance. It's about the balance. If we have to remind something that garlic and ginger have some interaction with anticoagulation and the effective of beta blocker, digoxin, and calcium blockers. This is the take-home message. And thank you very much for your attention. I hope it was helpful for you. Thank you.
It was very interesting. Thank you. Dr. Azza, would you like to comment?
No, thank you so much for this very interesting end of the meeting. Yes, this is very nice. We have to search for it. I hope then doctors have got good idea from this. It was very elegant and very smart today. This was a very nice case. Just to review the presentations of ventricular arrhythmias in the setting of coronary artery disease. We have just the point I'm emphasizing on is the timing of the ventricular arrhythmias from the beginning of the acute coronary syndrome. Is it within the first 48 hours, after that, and then after 40 days? Always think about this. Think about the systolic function of the patient. pre the situation, pre-acute coronary syndrome, and post what had happened to the LV, if he had complete revascularization or not. This is very important to have a good decision. The drawback is that we don't have wearable ICDs. I thought that this was only in Egypt, but it seems that it is a big problem. We are searching for a solution for this, but because sometimes we don't know, we cannot discharge the patient, and he's very liable for ventricular arrhythmias, and this is a big problem because he will not stay in the CCU for a very long time. That's it. Thank you so much.
Thank you. We can do the debriefing now. I'm going to share my screen. I made things easier.
Thank you.
Hi, Dr. Mona.
All right, hang on.
The second page.
What could have they done to help label and identify the patient's feelings? How could they have improved on this? Dr. May, Dr. Azza, Dr. Amna, how do you think they could have improved this?
سامحني. I have to go to put a tick in this question in this or I have to comment orally.
Can you comment, please? Just on the ones that they're not getting 5s and 4s, like this one. Helping patients label and identify their feelings. They're not getting the full mark here. Why? How could they have improved on this?
ما فهمتش والله.
شوف بختار ديكرام تاعها.
بختار ديكرام ما فيش. I don't see anything in the screen. Only tachycardia debrief page.
Yes, here. Can you help patient label and identify their feelings? They're getting 3s out of 5. Do you think they deserve more? And they deserve 3, why? Why do they deserve only 3?
Who put 3?
So you think they deserve more than this?
They deserve more than this.
Okay, and display defective nonverbal behavior? They deserve more than this.
Dr. Mona, we don't see the results on our screen. We just see the page of tachycardia debrief. So if you can put the results, so Dr. Alouche can understand the.
Can't see the results.
Because she can't see the results. So helping patient express his feeling. خدينا 3 sur 5.
ما يصيرش أقل حاجة خدينا ثم نسخة
Can you see it now? Do you see the screen now?
Only the page where it's written case 7, case 8, case 9.
Tachycardia debrief.
You can't see
we can't see the results.
About now?
No.
You can't see the results. I don't know what to do. I'm sharing it. Can you see it now?
Okay. Yes, we see it.
Okay. Well, I just
عملت the capture.
first questions. You're getting ones. This one, do you think they deserve this, or should they get more than this?
I don't think that we had to encourage question while the patient had a heart attack and STEMI.
Yes, that was an emergent situation. You're right.
Yes.
I agree. Yes, it's true.
How do you feel?
History, you're getting 5s mostly. Dr. Aiza, Dr. Amna, Dr. Mai, would you like to comment? Do they deserve 5s or 3s?
Other body systems. I think it's good.
Local cardiac exam. Why are they getting 3 for investigations? What's wrong with their investigations? Can anyone comment? Who made? Huh? Electrolytes.
Now they put the chloride.
Electrolytes were on the presentation.
No further حطيت لي حطيت normal renal function ومن بعد حطيت no further abnormalities. مادام ما j'ai pas précisé هكا دوتيفيكاسيون particulier.
So you should have elaborated a little bit more on the electrolytes.
She said that all the
lab tests, all other lab tests were normal.
Not in specificity the electrolytes.
I think you should have concentrated. You need to.
Yeah.
You should have mentioned it separately. I agree.
Sure.
It's important for the arrhythmias. Diagnosis. Why? I think. Who put 4? Can you tell us why you put 4?
For what?
For what?
For differential diagnosis?
There is no differential diagnosis, I think. As said Dr. Azza, we have to consider only VT. There is no other cardiac arrhythmia to evoke in this situation.
The treatment, who wrote 4 for the treatment and why? Why do you think they should get a 4?
Why?
We don't have in Tunisia the wearable defibrillator. We mentioned it. We mentioned it, and we mentioned it in the guidelines.
No, I'm asking who wrote the 4? Who rated it at 4? Can you tell us why? Can you give us a reason why you rated this at 4? I'm asking everybody who wrote the 4? Okay, so it's a 5 then. And patient counseling 3. What do you think?
The patient was there. The patient there. But in guidelines, she discussed how to
if he had
manage the patient after if he survived.
Mm-hmm. Okay. Case analysis. Who? Green? Beginner? Can you please elaborate? Who wrote this one? Dakatra, if you write something, you have to tell us why. What's missing? What do you think is missing? Why did you rate them at beginner level? Because if you don't have an explanation, then we're just going to go with a higher one, proficient.
I think that's a mistake.
Okay. Most of things, no good. Good. Well, I think you did a great job. Thank you, Tunisia. Great job.
Thank you.
Thank you, Tunisia. Okay, moving on to Yemen. I'm gonna unshare my screen. Stop sharing.
كلهم نعملها.
Yemen. Thank you, Tunisia. Dr. Azza, Dr. Amna, would you like to comment?
We are with you.
Would you like to?
We are with you.
جاي بتضحكي لما نبدا يلا الحين كذا شفتي should we start